Imagine a patient undergoing a major abdominal resection. While you focus on the sutures and the bleeding, a microscopic war is raging within their cells. The surgical trauma triggers a catabolic storm, releasing catecholamines and cortisol that dismantle muscle tissue for fuel. Most students overlook this silent metabolic crisis, yet it dictates whether your patient walks out of the hospital or stays for weeks with a non-healing wound. The stakes are incredibly high. There is a fundamental misunderstanding regarding how the body handles lack of food. In simple starvation, the basal metabolic rate actually decreases to conserve energy, and the body primarily burns fat. However, in the surgical patient, the metabolic rate skyrockets. This hypermetabolic state forces the body to prioritize glucose, often breaking down vital skeletal muscle to get it. Understanding this distinction is the first step in preventing post-operative cachexia and multi-organ failure. We often focus on the surgery itself, but the outcome is frequently decided before the first incision. Malnutrition is a hidden epidemic in surgical wards, affecting up to 40% of patients. If a patient has lost more than 10% of their body weight in the last 6 months, they are walking into the theater with a significant handicap. We must use tools like the subjective global assessment to identify these vulnerable individuals immediately. Many junior doctors rely solely on serum albumin levels to gauge nutrition, but this is a dangerous trap. Albumin has a long half-life of 20 days, making it a poor indicator of acute changes. Furthermore, during the inflammatory response, albumin leaks into the interstitial space. Therefore, a low albumin level might reflect the severity of the illness or the inflammatory state rather than just the nutritional status. We need to look at pre-albumin for more immediate feedback. How much energy does a surgical patient actually need? While the Harris-Benedict equation provides a baseline, we must apply stress factors based on the condition. For example, a major burn can increase energy requirements by over 100%. Typically, a stable surgical patient requires 25 to 30 kilocalories per kilogram of body weight daily. Overestimating is just as dangerous as underestimating, as overfeeding can lead to hepatic steatosis and difficult weaning from ventilators.
Proteins are the workhorses of healing. Without adequate amino acids, the body cannot synthesize collagen or mount an immune response. In the post-operative phase, protein requirements jump to 1.5 or even 2 grams per kilogram. If we fail to provide this, the body will harvest its own respiratory muscles to find these building blocks. This leads to pneumonia and prolonged mechanical ventilation. We are effectively watching the patient consume themselves to survive. To truly know if our nutritional intervention is working, we must look at nitrogen balance. Nitrogen is the unique component of protein, and by measuring urea nitrogen in the urine, we can calculate how much protein is being lost. A negative nitrogen balance indicates that the patient is in a catabolic state. Our goal is to achieve a positive balance, ensuring that the intake of nitrogen exceeds the output, which signifies an anabolic healing state. The ratio of carbohydrates to fats is a delicate balance. Glucose should provide about 60% of non-protein calories, but excessive glucose leads to hyperglycemia, which impairs neutrophil function and increases infection rates. Lipids are a dense energy source and provide essential fatty acids, but they must be infused carefully to avoid suppressing the immune system. We often use a mix to maintain a respiratory quotient that doesn't overtax the patient's breathing capacity. Macronutrients are only part of the story. Without zinc, wounds won't close. Without vitamin C, collagen cross-linking fails. We often see patients who are getting enough calories but are still failing to thrive because we ignored trace elements like selenium and copper. These micronutrients act as cofactors in enzyme systems that manage oxidative stress. In a stressed surgical patient, these stores are depleted rapidly, yet they are rarely mentioned in the standard round. The golden rule of surgical nutrition is, if the gut works, use it. Enteral nutrition is vastly superior to parenteral nutrition. It maintains the gut mucosal barrier, preventing the translocation of bacteria from the intestine into the bloodstream. When we bypass the gut, the intestinal villi atrophy quickly. This turns the gut from a protective barrier into a source of systemic sepsis. Even a small amount of trophic feeding can make a life-saving difference.
The traditional practice of keeping patients nil by mouth for days after bowel surgery is being dismantled by ERAS protocols. Enhanced recovery after surgery emphasizes early oral or enteral intake. Research shows that early feeding reduces the duration of ileus and lowers the risk of infectious complications. We no longer wait for the first bowel movement to start nutrition. The paradigm has shifted from passive waiting to proactive metabolic support from day one. In severe cases, we move beyond standard nutrition to immunonutrition. These are formulas enriched with arginine, glutamine, and omega-3 fatty acids. These specific nutrients modulate the immune response and improve microcirculation at the surgical site. Arginine in particular enhances T-cell function and hydroxyproline deposition in wounds. While more expensive, these specialized formulas can significantly reduce the incidence of surgical site infections in high-risk patients undergoing major elective gastrointestinal surgery. When enteral feeding is impossible, such as in high-output fistulas or complete bowel obstruction, we turn to total parenteral nutrition. But TPN is a double-edged sword. It requires central venous access, which carries risks of pneumothorax and catheter-related bloodstream infections. Long-term TPN can cause cholestasis and gallbladder sludge. It bypasses the liver's first-pass metabolism, which can lead to complex metabolic imbalances. It must be managed with extreme caution by a multidisciplinary team. One of the most dangerous phenomenon is refeeding syndrome. When you introduce nutrition too quickly to a severely malnourished patient, the sudden surge in insulin causes a massive shift of potassium, magnesium, and phosphate into the cells. This leads to a precipitous drop in serum levels, causing arrhythmias, heart failure, and death. You must start low and slow, monitoring electrolytes several times a day. It is a terrifying paradox where feeding the patient can actually kill them. Nutrition is not a set-and-forget order. We must monitor daily weights, fluid balance, and blood glucose every 6 hours. Electrolyte panels must be checked daily in the acute phase. We also look for physical signs. Is the edema resolving? Is the surgical wound showing healthy granulation tissue? These clinical markers are just as important as the numbers on a lab report. A surgeon who ignores the patient's nutrition is ignoring the foundation of their own work.
For the very first sentence, you must consider how you support nutrition when you manage fluid management. Most nutritional formulas are 70 to 80% water. Overhydrating the patient while trying to meet their caloric needs can lead to pulmonary edema and tissue swelling, which actually impairs the delivery of oxygen and nutrients to the wound. We must calculate the free water in our feeds and adjust the intravenous fluids accordingly. It is a constant, dynamic titration that requires the surgeon's full attention every single day. Most clinicians overlook that in the hypermetabolic state, the body's reliance on glutamine becomes so absolute that it is classified as a conditionally essential amino acid. Depletion of these specific stores in the skeletal muscle is the primary driver of gut mucosal atrophy and subsequent bacterial translocation. This specific biochemical failure often occurs within the first 48 hours post-injury, long before visible signs of malnutrition or weight loss ever manifest in the clinical setting.